Imagine a medical condition that fundamentally alters the daily lives, the physical comfort, and just the dignity of 70% of women.
Hmm.
Now imagine that despite it being that staggeringly common, only 7% of those women ever received the treatment that could, effectively cure it.
It's incredible.
Right. Today, we are shining a very bright light into this massive medical blind spot. We are doing a deep dive into women's pelvic and vulvovaginal health, which is a landscape that is incredibly murky, often shrouded in silence, and frankly, wildly undertreated.
Yeah, the gap between the sheer volume of women suffering and the lack of clinical intervention is, well, it's one of the most glaring disparities in modern medicine today. What we are exploring today is this realm of healthcare where patients are just frequently conditioned to accept physical degradation as a normal part of aging.
Like it's just something you have to put up with.
Exactly. And where silence is often the default symptom.
And breaking that silence is the mission of this deep dive. We've gathered this huge stack of medical guidelines, patient protocols, and clinical studies, and we're going to decode the jargon for you.
And we have some fantastic sources today.
We really do. We've got clinical guidelines from the BSSM, that's the British Society of Sexual Medicine, and the European Menopause and Andropause Society.
Hmm.
We're also looking at patient info from the Royal College of Obstetricians and Gynecologists, urgent care protocols from Andela Abjin, Frontiers in Medicine Systematic Review on Regenerative Therapies, and some clinical insights from ALA Sexual Wellness.
Right, and pulling all of these disparate specialties together gives you a really comprehensive roadmap. The goal here is to equip you with the vocabulary and understanding the difference between normal aging, a chronic condition that is frequently misdiagnosed,
Right.
what cutting-edge regenerative treatments actually do at a cellular level, and crucially, what constitutes an absolute medical emergency.
Yeah, let's jump straight into that shocking statistic we started with, because it perfectly illustrates the systemic gaslighting in women's health.
Yes, let's do it.
The BSSM highlights that 70% of postmenopausal women have symptoms of something called Genitourinary Syndrome of Menopause, or GSM,
Yeah.
yet only 7% get treated. Let's unpack what GSM actually is, because, for a long time, the medical world used a frankly insulting term for it.
They did. Prior to 2014, the prevailing medical terminology was vulvovaginal atrophy, or atrophic vaginitis.
Ugh, atrophy. Just sounds terrible.
Beyond sounding purely dismissive, it was clinically inadequate. The shift to the term genitourinary syndrome of menopause was essential because it broadened the diagnostic scope.
Right.
The old terms basically failed to account for the lower urinary tract symptoms that are directly, inextricably linked to low estrogen. So GSM encompasses the entire environment, both the vulvovaginal changes and the urinary issues.
So we are talking about a massive, sweeping physiological shift here. When estrogen drops during menopause, the physical landscape of the genitourinary tract completely transforms, right?
Clearly.
The tissue loses its rugae. Those are the natural accordion-like folds that give the tissue its ability to stretch and recoil. And the epithelium, the surface lining, becomes friable.
That's a great word to highlight.
Yeah, in medical jargon, friable basically means the tissue becomes so thin and delicate that it behaves almost like wet tissue paper. It tears and bleeds with barely any friction at all. I've heard people compare this to a lush garden turning into a desert, but structurally, it feels more like taking the mortar out of a brick wall.
Oh, that's a perfect analogy.
Without that estrogen binding it together, the whole structure just becomes brittle and starts grinding against itself.
The mortar analogy captures the mechanical failure perfectly.
Mm-hmm.
And the mortar of estrogen doesn't just hold the vaginal walls together. Estrogen receptors are densely packed throughout the urethra, the pelvic floor, and a highly sensitive area called the bladder trigone, which is a smooth, triangular region at the base of the bladder.
Okay.
When those specific receptors are starved of estrogen, the smooth muscle in the lower urogenital tract physically thins out and weakens. That thinning is the biological mechanism behind the sudden urinary frequency, the intense urgency, and the recurrent UTIs that so many women suddenly experience postmenopause.
Because the barrier is just gone.
Exactly. The tissue is literally too thin to provide a robust barrier against bacteria or to even hold back the pressure of the bladder.
And here's where the situation gets incredibly frustrating for me. The treatments for this, like systemic hormone replacement therapy, localized vaginal estrogens, or DHEA inserts, they are highly effective and remarkably safe.
Very safe.
The guidelines we're looking at even state that localized therapies, like a low-dose vaginal estrogen cream, are generally safe for women with a history of estrogen receptor-positive breast cancer. The fix exists. The tissue physiology can literally be restored. But the BSSM notes that 70% of healthcare professionals admit they rarely or never ask about vaginal dryness.
Yeah, that's the tragedy of it.
Is this just doctors feeling awkward, or is this a deeper failure in how we value women's quality of life as they age?
Honestly, the evidence points to a systemic failure masked as polite awkwardness. The prevailing cultural attitude, unfortunately shared by many patients and physicians alike, has long been that this discomfort is just your burden to bear, a natural consequence of getting older.
Right, just deal with it.
Exactly. But when you examine the efficacy of localized vaginal estrogen, which delivers such a minuscule dose that it typically doesn't even require monitoring of the uterine lining, it becomes clear that failing to initiate this conversation is a fundamental failure of care. The tissue can be revitalized, but the patient is rarely offered the tool to do it.
So we have this systemic lack of estrogen causing widespread brittle tissue. But the lack of estrogen isn't the only thing causing these structural cracks.
No, it's not.
Sometimes the skin undergoes drastic, chronic changes that have absolutely nothing to do with menopause, yet they get lumped into the exact same bucket of just put some cream on it and deal with it. Which brings us to lichen sclerosis.
Yes. Lichen sclerosis, or LS, is a chronic inflammatory skin disease. And according to the data from the Royal College of Obstetricians and Gynecologists and EMS, it primarily targets the vulvar and perianal areas.
And what does that look like clinically?
Clinically, it presents as ivory white, thinner than normal, highly fibrous skin. The hallmark symptom that drives patients to the doctor is intense, often unbearable pruritus.
Severe itching.
Right, severe itching. But beyond the immediate discomfort of the itch, LS causes devastating structural destruction over time. We see the physical loss of the labia minora as the tissue fuses together and the actual burying of the clitoris under thick layers of scar tissue.
Wow. And the diagnostic delay for LS is an absolute tragedy. Women go to their doctors complaining of this unbearable itching, and they're handed an over-the-counter cream for thrush, or they're told it's just the postmenopausal dryness we just talked about.
Exactly. It's a constant cycle.
The data shows this cycle of misdiagnosis leads to diagnostic delays of up to 5 years. 5 years of intense pain, progressive scarring, and the literal erasure of their anatomy before someone finally performs a simple punch biopsy to confirm it's actually LS.
And that delay is particularly dangerous because LS is heavily linked to a broader systemic issue. It is considered an autoimmune condition. Nearly 30% of women with confirmed lichen sclerosis also have an autoimmune thyroid disease.
30%, that's huge.
It is. Furthermore, LS is characterized by something known as the Koebner phenomenon. This is a fascinating but destructive medical quirk where physical trauma to the skin actually triggers or dramatically accelerates the disease process at the exact site of the injury.
It's like a glitch in the body's repair system. You get a simple microscopic scratch, maybe from tight clothing or just from scratching the itch itself, and your immune system sends in the wrong repair crew.
That's exactly what happens.
Instead of healing the scratch with normal skin, your body overreacts and paves over it with a chronic, spreading, fibrous scar.
Because the immune system is actively attacking the tissue, the standard treatment requires potent topical corticosteroids, like clobetasol propionate, or sometimes calcineurin inhibitors.
I know those you.
Calcineurin inhibitors are essentially medications that act like a volume dial. They turn down the local immune system's overreaction so the tissue can breathe and heal. But the clinical monitoring doesn't stop once the itching fades. There is a persistent, small, but very real risk, roughly 5%, that LS can develop into vulval intraepithelial neoplasia, or VIN.
Which is a precancerous cellular change.
Right, a precancerous change that can lead to squamous cell carcinoma.
Which is exactly why you can't just ignore it and hope it goes away. But wait, I'm looking at that massive 30% overlap with autoimmune thyroid issues, and I really have to push back on standard medical practice here.
Go for it.
If the autoimmune link is that statistically undeniable, and we know there is a devastating 5-year diagnostic delay, why isn't a thyroid diagnosis an automatic trigger for a mandatory vulvar health screening? Why are we forcing patients to endure half a decade of structural loss before anyone connects the dots?
The lack of cross-screening just highlights how heavily siloed modern medicine remains. An endocrinologist focuses exclusively on the thyroid gland and blood panels. A gynecologist focuses on the reproductive tract.
Right, they aren't talking to each other.
Exactly. Bridging that gap with an automatic interdisciplinary screening protocol would make perfect clinical sense. It would allow doctors to catch the Koebner phenomenon before the irreversible scarring begins. Until clinical guidelines mandate that cross-specialty communication, the burden unfortunately falls entirely on the patient to report the symptoms.
Which relies on the patient knowing that what they are experiencing isn't just normal aging.
Precisely.
We have to break those silos down. So, we've got LS attacking the surface skin, turning it fibrous and scarred. But if we go just a bit deeper, under the surface, there's another massive structural collapse happening as we age. The body's actual internal scaffolding is failing. And that directly
Collagen. Insights from Asexual Wellness outline the specific biomechanics of how vaginal collagen shifts, particularly after the age of 40. Collagen is not a single, uniform substance.
Right, there are different types.
Yeah, it comes in several different types. The vaginal walls and the pelvic floor rely heavily on a specific, highly flexible type of collagen to maintain elasticity, support the surrounding smooth muscle, and allow for natural expansion and contraction.
But as time goes on, the body essentially stops manufacturing the flexible stuff and starts retaining a stiffer, much more rigid type of collagen. I like to picture it like an old mattress.
Oh, that's a good way to look at it.
When you buy a brand new mattress, it has these plush, bouncy springs that support you perfectly. But over a decade, the plushness degrades, the springs lose their bounce, and you're just left lying on the rigid, unyielding metal frame.
And the functional consequences of losing those bouncy springs are immediate and severe. The urethra relies on the plush, elastic support of the vaginal wall for physical backing. When the flexible collagen diminishes, the urethra loses its foundational support. This mechanical failure leads directly to stress urinary incontinence, or SUI. That is the involuntary leaking of urine when you laugh, cough, sneeze, or do jumping jacks.
Just from the downward pressure.
Right. The sudden downward pressure from the abdomen simply overpowers the weakened seal of the urethra because there's no structural backing to hold it shut.
This is where I get really frustrated with how our culture handles women's health. We see it constantly in commercials for bladder pads. We hear it in stand-up comedy. This absolute cultural normalization of incontinence.
Oh, everywhere.
Oh, I laughed so hard I peed a little. It's just a quirky part of being or getting older. Why are we socially conditioned to accept this as a joke? Why aren't we treating it as a mechanical failure that can be structurally rehabilitated?
Normalizing the dysfunction is a defense mechanism against embarrassment, honestly, and it thrives on a lack of awareness about modern treatment options. Many patients assume the only permanent fix is highly invasive sling surgery. However, the NICE consultation documents highlight incredible advancements in conservative structural management. A prime example is transcutaneous electrical neuromuscular stimulation, or TENS.
When I hear TENS, I think of those little sticky pads a physical therapist puts on a sore shoulder. But we are talking about wearable tech here.
Yeah, the NICE guidance evaluates a specific modern design where non-implanted electrodes are incorporated directly into a garment that is worn exactly like a pair of bicycle shorts.
Wait, like actual shorts you just put on?
It's exactly like bicycle shorts. You wear them, and the device delivers targeted electrical stimulation that artificially forces the pelvic floor muscles to contract, isolating and rebuilding strength and the precise muscles needed. It's prescribed for daily sessions over a 6 to 12-week period.
Wow.
It completely removes the guesswork of doing Kegel exercises incorrectly by using targeted neuromuscular pathways to physically bulk up the muscle supporting the urethra.
So you are essentially putting the pelvic floor through a highly targeted automated gym routine.
That's a great way to frame it.
TNS is amazing if you have enough muscle and nerve function left to stimulate. But what if those biological materials themselves are depleted? What if the mattress springs are so far gone that an automated gym routine simply isn't enough?
That's the big question.
That's where we get into the regenerative side of the synthesizes, which reveals some truly futuristic treatments actively forcing the body to manufacture new tissue.
Right. The Frontiers Systematic Review dives deep into injectable platelet-rich plasma, or PRP, specifically for treating stress urinary incontinence. PRP is an autologous treatment, meaning it is derived entirely from your own blood.
Okay, so how does it work?
A blood draw is taken, spun down in a centrifuge, and the plasma is isolated to concentrate the platelets. These platelets are incredibly rich in specific signaling proteins known as growth factors, namely PDGF and VEGF.
Let's translate those growth factors because they are the real magic here. It's like your body has this dilapidated, crumbling building site. Injecting PRP is like sending in a highly specialized elite construction crew directly to that site.
Yeah.
They don't just patch the holes, they release chemical signals that force the local environment to start manufacturing brand new materials from scratch.
To break down that construction crew's jobs, VEGF, or vascular endothelial growth factor, is the chemical signal that triggers angiogenesis. It basically tricks your body into building brand new blood vessels from scratch, bringing a massive influx of oxygen and nutrients to the starved tissue.
Okay, and the other one?
Meanwhile, PDGF, or platelet-derived growth factor, wakes up dormant cells called fibroblasts, commanding them to synthesize new, flexible collagen. The urodynamic results in the Frontiers review are compelling.
What did they find?
The data shows that PRP injections significantly improve a metric called abdominal leak point pressure, or ALPP. This measures the exact amount of physical pressure the bladder can withstand before the seal breaks and leaking occurs. After PRP, that pressure threshold goes up significantly. Plus, the adverse events are remarkably mild and self-limiting, mostly just temporary spotting or mild discomfort at the injection site.
Okay, wait, I'm looking at these specific PRP results in the Frontiers study, and something isn't adding up for me.
What's that?
The study notes that while the bladder can hold more pressure, the ALPP improves. Another metric, the functional profile length of the urethra, or the FPL, does not actually change. The FPL is basically the physical length of the urethra seal. If the physical length of the seal isn't getting any longer, is the PRP actually rebuilding tissue, or is it just acting like a cosmetic filler? Like, is it just temporarily swelling the area to mask the incontinence, or is true long-term regeneration actually happening?
That is the exact analytical question researchers are grappling with right now. Because the FPL, the structural length of the seal, remains unchanged, the data suggests that PRP isn't fundamentally altering the macroanatomy of the urethra. It isn't building a longer pipe.
So it is just filler.
Not exactly. It isn't just a simple mechanical bulking agent either. The increase in the pressure threshold suggests that the quality and tone of the tissue within that existing length have improved at a cellular level. The new blood vessels and the fresh collagen make the existing seal tighter, plumper, and more responsive.
Got it.
But your skepticism is completely valid. The Frontiers review explicitly states that while the short-term regeneration is real, we still need larger, standardized long-term trials to prove how durable these newly minted tissues are over several years.
It's a fascinating frontier, and we see this exact crossover between restoring function and restoring aesthetics with the collagen treatments, too.
We do.
The Allosexual Wellness source details a procedure known as the labial puff, which uses hyaluronic acid dermal fillers, the exact same science used in facial aesthetics, to immediately restore hydration and structural volume to the labia majora. It counters that age-related volume loss, providing a physical cushion with results lasting 9 to 12 months. It offers immediate symptomatic relief and physical protection, while the longer-term structural work, like PRP or TNS, takes effect.
The availability of these therapies illustrates a massive paradigm shift. We are moving away from an era where patients were told to simply endure silent suffering and moving into an era where patients can actively choose to rehabilitate, stimulate, or volumize these tissues based on their individual symptoms and anatomical goals.
But, while PRP and TNS offer a roadmap for rebuilding tissue over a period of months, some pelvic symptoms don't give you the luxury of time.
Very true.
There is a sharp, undeniable dividing line between book an appointment for next month and go to the emergency room right now. We really need to talk about the absolute red flags.
Yes, distinguishing between a chronic issue and an acute crisis is vital for patient safety. The clinical guidelines from Annandale-Obgen provide a very clear framework for separating urgent care, meaning you need to be evaluated within a few days from an absolute emergency room visit.
Let's start with the ER criteria.
Okay, if you experience severe, sudden pelvic pain that is accompanied by dizziness or fainting, you go to the ER. This presentation is highly suspicious for ovarian torsion, where the ovary literally twists on its own stalk, cutting off its blood supply. If not untwisted surgically and rapidly, the tissue dies.
Or if you have a positive pregnancy test combined with sudden, severe, one-sided pelvic pain.
Yes, that combination is the classic textbook warning sign of an ectopic pregnancy, where the embryo implants outside the uterus, most commonly inside a fallopian tube.
And that can rupture.
Exactly. As it grows, the tube can rupture. A ruptured ectopic pregnancy causes catastrophic internal bleeding and is a highly lethal medical emergency. You do not wait to call your doctor on Monday morning. You go to the emergency room immediately.
I think it's crucial here to acknowledge the emotional weight of medical gaslighting we discussed earlier. Women are so frequently conditioned to endure terrible pain, to endure bad periods, that when something catastrophic actually starts happening, the internal monologue is often, oh, it's just a bad cramp, I'm overreacting, I'll just take some ibuprofen and lie down.
That habit of minimization is extremely dangerous. You must trust the severity of the sudden onset. Which brings us to another critical symptom, bleeding. The Annandale Protocol specifies that postmenopausal bleeding is an urgent, same-week issue.
Any bleeding at all.
If you have gone 12 consecutive months without a period, any bleeding, even just a tiny pink spot on the toilet tissue, must be clinically evaluated. Connecting this back to the RCOG source, postmenopausal bleeding is the primary early warning sign for serious conditions like endometrial abnormalities or the precancerous VIN we discussed earlier.
And what about fever?
Yeah.
Because sometimes things just feel off down there.
A fever combined with newly onset pelvic pain or an unusual foul-smelling discharge is an urgent red flag. It indicates a rapid, acute infection, such as pelvic inflammatory disease. If left untreated even for a few days, the inflammation can cause irreversible scarring in the reproductive tract and lead to lifelong chronic pain.
But heavy bleeding is such a vague warning. Every woman's definition of heavy is different, especially if she has a history of brutal periods. How do you actually know if you're just having a terrible, heavy week or if you're losing a dangerous, life-threatening amount of blood?
The clinical threshold removes the guesswork. If you are bleeding heavily enough to completely soak through a thick pad or a super tampon every single hour for 2 consecutive hours, you have crossed into dangerous territory.
Every hour for 2 hours.
Right. Furthermore, if you are passing blood clots the size of a golf ball or larger, or if the bleeding is accompanied by lightheadedness, a racing heart, or sudden shortness of breath, your body is showing signs of significant volume loss. That physiological response requires immediate medical evaluation to stabilize your blood volume, not a wait-and-see approach.
Soaking a pad an hour for 2 hours, golf ball-sized clots, and feeling dizzy or out of breath. That is the indisputable line. Do not gaslight yourself or let anyone else minimize your symptoms if you hit that threshold.
Knowledge of these specific measurable thresholds is precisely what empowers patients to bypass their own self-doubt and demand the necessary care in the appropriate clinical setting.
Absolutely. Let's recap the journey we've taken today, because this information is your personal toolkit. We started by breaking the silence on that staggering disparity. 70% of women suffering from the physical degradation of GSM, while only 7% ever get the localized estrogen mortar needed to fix it. We decoded the tragic 5-year diagnostic delay of lichen sclerosis and the cellular immune glitch of the Koebner phenomenon.
And we examined the structural collapse of vaginal collagen that leads to stress incontinence, and we explored how targeted wearable 10NS technology and the elite regenerative construction crews of PRP injections are actively forcing the body to fight back against that mechanical failure.
And finally, we established the absolute red flags, the sudden pain, the torsion and ectopic risks, the fever, and the exact blood loss thresholds that demand an immediate trip to the ER.
Right.
By understanding the profound difference between a slow, treatable tissue change and an acute, life-threatening emergency, you are now armed with the vocabulary to advocate for your own body. You have the knowledge to demand proper comprehensive care.
The overarching takeaway here is that you no longer have to accept the antiquated narrative that pelvic pain, structural loss, or incontinence are just natural, unavoidable consequences of aging. The science and the cellular therapies have moved far beyond that limitation.
Which leaves us with a final, provocative thought for you to mull over. Given that 70% of postmenopausal women suffer from the physical, structural degradation of GSM, and given that the localized treatments and cellular regenerative therapies we've discussed today are highly effective, what if routine gynecological care for older women shifted entirely from a reactive, disease-based model to a proactive longevity model?
That would be revolutionary.
Right. What if, in the very near future, pelvic tissue regeneration and structural support are treated as routinely and preventatively as getting your teeth cleaned at the dentist?
A proactive approach like that would completely redefine the physical reality of the aging experience for half the population.
It really would. It's time to stop wandering blindly through the diagnostic muddy waters, and it is definitely time to stop accepting the erosion of your own health as your only destination.